Hello, everyone, and happy ARD Awareness Day. My name's Eddie Del Rio from the Sampler Society. Thank you for joining us. Today, we have a very special guest. We have an AERD expert, author of the AERD Guide for Patients, and AER director of the Scripps Clinic in San Diego, California. Today, he's going to be going over some interesting topics in AERD and also answer some questions for us. So thank you for all that submitted those. So without further ado, please join me in welcoming Dr. Andrew White. Thank you, Dr. White. Please go ahead.
Great. Thanks, Eddie. I'm going to share my screen. And I think I need to flip-flop it. Okay. Are you seeing the main slide?
Yes, I can see it.
Okay, great.
Yes.
All right, great. All right, thanks everybody. I've got my AERD shirt on, and it's really great just to be able to present with you. I think I had a recorded video a few years that I did a few years ago, but I haven't had a chance to do one of these live programs. And I know you've interacted with some of my other AERD colleagues. So I have about a 15-minute or maybe 20-minute presentation just with some updates and things that I think might be interesting for you, and then I'll be happy to take questions. So let's go through. Okay, so my first slide here is just a thank you. In the last decade or so, many of you have participated in research, some of it in questionnaires and surveys that we've sent out, and some of it in person with sample collection or trying new medications or new trials. And it's really huge to have that. We don't have a good animal model where we can learn a lot about AERD. We really have to study human patients, and it requires you to participate. And so, in my practice, many patients have been really generous with letting us collect samples or participate in research projects. So I really want to thank you, and those around the country that study AERD, I know, feel the same way. I thought I would just give a quick shout out to my mentor, and this is really how I ended up studying AERD. So this is Dr. Donald Stevens. If any of you came to Scripps back in the 80s or 90s for an aspirin desensitization, you probably met him and worked with him. So he actually was the first investigator in the world to try to desensitize and maintain patients on aspirin therapy, and ended up being a revolutionary therapy. And for a few decades, Scripps was one of the only places in the country where you could have this done. And so when I did my training here, we still had people flying in from many parts of the country, and so he was my mentor. And I ended up actually, I was in the Navy at the time, did my training at Scripps, went back to finish up my Navy time, and then came back. And around that time, he retired and really handed off a lot of what he had been doing to me. And I had the good fortune of taking over from him at that point. So I've spent the last almost 15 years now studying AERD, and it's really to this man. And when we think about the major contributions to where we are with AERD, a lot of it ends up with Dr. Stevenson. Okay, so here's the overview, just a few things I thought I would bring up today. The obvious point of discussion is COVID. Things have changed a lot for all of us, including AERD patients, and then taking care of AERD patients since COVID-19's occurred. So we'll talk about that. I'll just update you on what I think some of the main changes are to the AERD landscape in terms of treatment. I've been really interested in alcohol reactivity, and we did a study A few of you on the line may have participated in that. So I'll give you an update on that, and then some upcoming studies that we're interested in. So at the beginning of the pandemic, I know a lot of my patients called or during a consult or visit would want to know, what's the likelihood that something bad's going to happen if we get COVID? And it certainly was concerning with AERD. It's, generally associated with severe asthma, having a lot of inflammation in the sinuses. We were pretty worried. But then after about the first 6 months, we started to have some research that actually suggested maybe having a lot of eosinophils, like most of you have in your sinuses and your airway, it might actually protect a little bit. Not a lot, but maybe a little bit. Study looking at a large group of patients that were hospitalized with COVID, there were a lot less patients that had eosinophilic asthma in that group. So after all is said and done, we collected all the patients that we knew of in our various centers that study AERD, and we reported on all of those. Are there increased risks of patients needing to be intubated or having a severe outcome? And it really didn't seem like that was the case. So we are pretty confident that this is not a huge risk factor. Obviously, anyone who has really severe asthma, we are going to be a little bit more concerned, but it doesn't seem like it's an order of magnitude worse when you consider maybe some of the other comorbidities. And there's also no reason why there should be concern about using any of the current therapies for asthma, or I'm sorry, for COVID, if you get, even if you have AERD. The other big part of COVID is how it's changed how we deliver care, right? So I know many of you probably went maybe a year without seeing a doctor in person. We were doing a lot over telehealth, and that's difficult when we're dealing with asthma and polyps when we can't examine you. So, that led to a lot of decrease in our using aspirin desensitization, especially during the height of the pandemic. We have started to do a lot of telehealth, but depending on where you're located geographically, there can be a lot of differences. For example, at Scripps, we can't see patients out of the state if they're living outside of the state at the time of the telehealth visit. So there's some good and bad that goes with the telehealth. And then the other aspect of this with COVID was some of our most important tests, like spirometry, which is the breathing test for asthma, or the endoscopy, where either we or ENT looks up the nose. Those really put whoever's doing the tests at risk if the patient has COVID. And so we've needed to implement doing negative COVID tests before doing those. And that isn't great, just from a logistics standpoint, for patients who may have to come back a different day and get a COVID test in the interim. So those are the big changes. I think we're doing better working around this and making some of these, like getting a COVID test and making it routine before having you see ENT. But I'm sure a lot of you have experienced this. Okay, so what are the changes in the AERD landscape? So I would say there's been a tremendous change over the last 5 years or so. For 15 years, taking care of patients with AERD, for many of those years, we really didn't have anything new to discuss with patients. It was aspirin therapy and occasional small adjustments, maybe to the way we did sinus rinses and sinus surgery. But now we've seen a lot of new medications arrive. We have 3 biologic medications that have an FDA approval for nasal polyps. We have 6 biologics, which includes those top 3 that are approved for asthma. And so a lot of patients with AERD would qualify for any one of these medications based on their disease. One of the other big changes, and it's more evolved in the last 5 to 10 years, is that we now are pretty convinced that if you're going to go on aspirin therapy, we really want to do that right after surgery, because that really does the best job at preventing polyp regrowth. We're less enthusiastic about recommending it for patients who already have a big polyp burden in their nose. So I think that's been the third big change. And one of the other big changes actually is sort of related to that. This was a researcher that studies AERD. She's currently at Mayo Clinic, but was in the Bronx when she did this study. And she looked at AERD patients, and they did an aspirin challenge before surgery, before sinus surgery, when the nose was pretty full of polyps, and then did the same aspirin challenge about a month after surgery when the polyps were gone. And about a third of patients had a negative challenge. And it doesn't mean that the AERD went away. We know that that really doesn't happen after surgery, but it does tell us a lot about the disease, that the polyps that are present actually, could be viewed as sort of like a fuel source for the reaction. And when we do these challenges, even if it's negative, we would still interpret that you have AERD and should stay on aspirin. So I think these are the big changes that I've seen in the last 5 years or so. And I thought I would just compare and contrast the difference between a biologic and some of the other medications. A lot of patients ask me about this. So what a biologic is it is a medication that's created in some sort of living animal model. So in the old days, it used to be in a mouse or sometimes in a rabbit. Now it's made in a cell line, but it's an actual antibody. Just like our body makes antibodies to tetanus or COVID, this is an engineered antibody, and it's targeted to a very, very specific thing in our immune system. And after decades of testing a certain immune pathway, we become aware that that's really important in a specific disease. And so in the case of AERD, we know leukotrienes and eosinophils and mast cells are really important. So ways to target those are very attractive. And then we have to figure out if it's safe, and then finally figure out if it's effective. So the difference between the biologic and an oral medication is that most of the oral pill type of medications that we have, they may block a receptor, but they often have other effects. They're broken down into compounds that might also have effects. And if you compare a biologic to, say, prednisone or a steroid, there's a huge effect that prednisone has, very widespread compared to a biologic, which is much more targeted. Because biologics are antibodies, they can only really be given as an injection. So you won't find an oral way to do this, whereas most of the other medicines we use are oral or inhaled, right, or topical in the nose. And in general, the biologics are also quite a bit more expensive. We currently don't have any generics. And obviously with the other medications, it's a little more varied, but many of them do have generics and maybe not quite as expensive. And if I were to try to give you just a general way to think about a biologic, so if I asked you with this Jenga block here to go and get me this one piece of wood, you could do it two different ways, right? You could carefully pull it out and leave the rest of this intact, and that would be sort of what a biologic would do. Or you could just kick the whole thing over and go find that piece of wood and come bring it to me, right? The end result would be the same, but this pile of wood would be quite a bit different. And so I think that's a very crude way to think about this. The biologic is very, very precise and targeted. The other medications a little more broad, and it doesn't always mean that it's bad, it's just the difference. So I've been really interested in this idea of alcohol reactivity. The whole story on this really came from patients who would tell us that, why is it that every time I drink alcohol, I sneeze or I get congested or I have asthma? And after hearing enough of these stories, myself and then Dr. Tanya Laidlaw, who's in Boston, we both came to this conclusion at the same time that there's something going on here. And so we did that many of you may have participated in. It was about 10 years ago. And we just asked a lot of questions about, is there reactivity? And there definitely is in AERD. So about 80 to 90% of patients with AERD will have some sort of reactions when they drink alcohol. And I feel like I put this on the top line that it's just not fair. It's such a peculiar disease, AERD. You lose your sense of smell, you grow polyps in your nose, you have severe asthma, and you can't take NSAIDs, and then you can't drink alcohol, right? Such a weird combination. But we know that about 80% of patients with AERD have this problem, and it's only about 40% of patients with asthma in general. So about twice as likely, and then pretty unlikely in the general population. We know some things that we know are that the sensitivity to alcohol can improve when patients are on biologics or on aspirin therapy. So we ended up doing a challenge study in 8 patients. It took us a few years to get through doing all of these, but we found patients who had reactions with wine. We had them come into the office and actually drink wine here, and we did a variety of measurements, and they did it twice. We had them do it one time with cetirizine, which is Zyrtec, and Singulair. So they took both of those pills. Or the second time they did placebo, where there was just salt tablets that didn't have anything in them. And then we compared what happened when they drank alcohol. And so in that group, we had about 3 of them that had asthma when they drank wine, and none of them had asthma when we treated them with Zyrtec and Singulair. Most of the nasal symptoms were blocked, not all of them. And so we really came to the conclusion with this study that you can somewhat block these reactions, or at least they're related to histamine and what Singulair blocks. We know from our survey that red wine is the worst in terms of causing problems, then beer is second, and less likely hard alcohol. In my theory, and I'm going to have a little bit on the next slide, of why people have this is it's really related to the severity of the inflammation. The more inflammation you have, the more likely you are to have alcohol reactivity, and because AERD is so highly inflamed, that might be why people react. So there's a lot of theories, and I thought I would just go through some of these theories and shoot them all down. So one of the theories is that maybe there's something similar to aspirin in alcohol, but there's not. There's none of the enzyme that causes the reactions when you take aspirin or ibuprofen. There's none of that in alcohol. And even after we desensitize patients to aspirin, some of them will still react to alcohol. So it can't be related to that. I feel pretty confident that this is not the cause. Is it possibly just a allergy to ethanol, just like people develop an allergy to peanuts or shellfish? But that doesn't make sense. Patients don't have more widespread reactions, and it's really a completely separate problem from what's going on in the sinuses. There was a really interesting study, I think it was from Virginia, where they talked about polyphenols, or these really aromatic compounds that are part of alcohol. And I think this makes a lot of sense because red wine is the most common, and I think that has a lot of polyphenols, and then beer would have less, and then hard alcohol would have even less. But really, some of this can happen even with really just pure hard alcohol, arguing that this is probably not the only reason. I bet it is part of the reason, but maybe not the whole reason. Could it be that alcohol just sort of upregulates some of the in and of itself upregulates some of the leukotrienes that we know are really important? And possibly that's true, but we don't really have any studies to back that up. It also wouldn't really make sense that it would happen within 10 or 15 minutes, which is what a lot of you describe, where you drink alcohol and then 15 minutes later your nose is stuffed or you have asthma. And then another theory is that ethanol may just cause there to be more blood flow to the nose, just like you can get flushing sometimes where your face turns red with alcohol. And I do think that's another idea that makes sense, more so for the nose, but maybe not so much for asthma, where that may not, but that doesn't make as much sense that could be occurring. So you can see here, we've got a lot of theories, but not a lot of ideas that really completely paint the whole picture of what we're seeing. So we just truly don't know. My theory, and I think the best evidence is, like I said, this is really related to inflammation. And I think when we see people ultimately lose their intolerance to alcohol, it's usually when their nose and their sinuses are under good control with whatever medications that takes. Okay, and then wrapping it up, where are we at with some of our upcoming studies? We have 2 studies. We have one ongoing and one that's just getting ready to start. The first is a study where we are interested in seeing what changes are happening in immune cells and immune chemicals right after starting Dupilianab. So Dupilianab is a biologic that's used for polyps. And so what we're doing is we're doing a swab in the nose. We're doing it right before starting and then a month after starting Dupilianab. And we're able to do some pretty sophisticated genetic studies to really see all of the changes that might be happening, because we're interested in what things change the most and see if that gives us any clues as to why patients seem to do better with Dupilianab. So if you live local to San Diego and you're willing to come have your nose swabbed, we would love to have you. Just give a call to our clinic and we'll set that up. The other study, which we're hoping to start in the next few months, is looking at the effect of Dupilianab on aspirin reactions. So one of the big questions is, if you go on a biologic and you're not desensitized to aspirin, maybe a few years down the road, you're feeling really well, but we don't know how protected you are or how likely it is that you would still react to aspirin. And so that's the point of this study. There's 2 parts of it. The main part is just seeing if people still react when they're on Dupilianab. And then we're also looking at some very basic cells that we're interested to see what happens. And so that's something that in the future, if you hear about it and you're interested, again, please reach out. So my final slide here is, a plea for us all to work together. One of the reasons I actually love taking care of AERD is I really enjoy working with my ENT partners. It's a really great opportunity for collaboration. The allergists, we're experts on medical therapy. We love thinking about all the immune cells and different cytokines and chemicals that are being released. And the surgeons have a tough job because this is a pretty aggressive polyp-forming disease. So we really need their expertise, both in what type of surgery to do, whether surgery would benefit you. And I really enjoy having the chance to work with them, talking back and forth about patients. The other real important reason to have both of us working together is, I find it works best if we're able to stay on top of things. So checking spirometry regularly to make sure that the asthma is controlled, and then having someone looking up in the nose to see if there's any early signs that our treatment's not working. Because if that's the case and we're starting to see polyps, we really want to jump on it, way early before things get out of hand and maybe it gets to the point where another surgery is necessary. So that's my overall summary. I hope you find that somewhat helpful, and then I'll stop sharing. And Eddie, I'm going to turn it back to you.
Okay, great, Dr. White. Very informative. So with that, we'll move on to some of the questions that were submitted. So kicking it off, Alicia Buchanan asks, what are some ways we can prevent or help reoccurring sinus infections?
Okay, great question. So, I think that there's a couple ways to think about these sinus infections. Sometimes they're not bacterial sinus infections. In fact, a lot of times they're not bacterial. And sometimes it's a flare up of the chronic sinusitis. So if the underlying sinus problems aren't well controlled, it can really wax and wane a lot, and just, having a mild viral illness, things will flare up and get out of control. So one of the most important things is just controlling the underlying disease. And I would say that if someone's having recurrent, 3 or 4 times per year getting sinus infections, then we need to maybe go back and see, are we actually controlling the underlying disease properly? Another reason for recurrent sinus infections is if the polyps or the sinus inflammation is blocking the sinus from draining. That's a surgical issue. And so if someone were to tell me that they were having recurrent infections, one of the first things I'd want to do is look at a recent CT, or if they recently saw their ENT, what did their scope look like? And then the third thing is something we don't think as much about, but is whether there could be an immune deficiency. It's not super common in AERD, but this is what we do in immunology, is we look for patients that have maybe a small defect where they can't make antibodies properly. And in patients with chronic sinusitis, they're actually a little more likely to have that. So that's the job of the allergist, to look for that. And that would actually be treated differently. And so we would want to know that up front. So those would be my 3 main things to say: control the underlying disease better, think about whether there's blockage and you need surgery, and then maybe have an immune deficiency evaluation.
Okay, great. Next, we have Ruth Harvey. She's asking, what's the best treatment for those that cannot access Dupixent or tolerate aspirin? Is surgery after 2 or 3 years better than living with symptoms even if problems return?
Yeah, so a 2-part question. I don't think I can answer exactly the best treatment. If you can't tolerate aspirin, then it's going to have to be some, other medical therapy. As I said earlier, there's actually 3 biologics that are approved for polyps. And so if Dupixent's not an option for whatever reason, there are other options. And so you should talk to your allergist about that. And these are all medications that most allergists are going to be very comfortable with. So that would be the one important thing up front. The second thing is, is surgery, worth doing even if you need it repeatedly? And the answer is really sort of back at you. How symptomatic and impaired are you? How much benefit do you get? If you get a lot of benefit for like a year after surgery, then maybe it is worth it. But there's risks obviously to surgery, both with recovery and then just getting the surgery at all as well. So I'd have that discussion with the patient, but I'd really try to see what else can we do from a medical standpoint to prevent or delay surgery. But there are some other options that you should talk to your allergist about.
Thank you. Next up, Carla Merklovitz asks, and you briefly touched on this, is there a genetic component to our disease?
Yeah, so there is at some level. We don't really have any good twin studies. That's really the best way to think about this, is to look at identical twins and then fraternal twins and then siblings and try to tease it out. We didn't know that there are, they're called SNPs, which are small little, variations in our genetic code that put us at risk. So those probably do run in families. But, as I think all of you know, this is a condition that really suddenly starts, or usually starts pretty suddenly in adult life. It's not something that we're born with. So there is definitely a huge environmental component where there might be a virus that triggers it, or some other, a lot of this we don't know. And then we do think that probably it's a combination of that exposure plus having some genetic risk factors.
Interesting. Okay, next up, Tim Samet asks, are there any links for ARD to weight gain or vision loss?
Those are good questions. I've never heard of vision loss. The for weight gain, I think that's a harder question to answer because I don't know of any study that really looks like specifically at BMI related to AERD. But a lot of having AERD would affect weight. So, having difficulty with exercise with that from asthma would obviously have an effect on weight. Having steroid bursts, some people are very sensitive to the effects of steroids and could gain weight and have a difficult time losing it from that. So those would definitely be reasons why there could be a connection, but I'm not aware of any specific, direct connection between those two.
Okay. Kind of similar to a previous question, but Jennifer Devilis asks, if symptoms feel well managed, is there any reason or advantage to getting sinus surgery? Do polyps contribute to the disease beyond obstruction?
Yeah, it's a great question. The short answer, I would say, is no, there's no reason to get surgery if you're feeling like things are controlled. We do know from that study I mentioned that having a lot of polyps does probably sort of fuel the aspirin reactions in some people. But I don't know if that would be a reason to get surgery in and of itself. A lot of times, patients can get control of their disease from a symptom standpoint and feel relatively well, but still have polyps on exam. And that's okay, in my opinion. Having polyps present doesn't mean that they need to get taken out. So, I really focus on symptoms, quality of life, how much impairment there is, and really what your goals are as a patient. Sometimes patients have some nasal congestion, but they're willing to live with it, and would prefer to not make any changes in their therapy. So yeah, I don't feel like there's any reason to get surgery just because of what someone sees on exam.
Thank you. You talked about this a little bit in your slides. Jan Fellman asks, are there any new treatments on the horizon?
Yeah, so a couple things I would say. There are 6 biologics. 3 of them are approved for polyps, and a few of those 6 are also looking at polyps. So some of those may be other options. We'll see if they're better, similar to what we already have. There's actually a lot of interest in even other biologics. It's a very easy way to create a medication. You can pretty quickly in the lab biologic and sort of target whatever you want to. And so there's a lot of other targets that are being looked at for polyps. And some of those make a lot of sense for AERD. So there are some of those that are sort of, starting to get out there on the horizon. There's also an oral pill that is in a clinical trial right now. It's called Ifetroban. Some of you may have participated. They're still enrolling patients. And so that would be another treatment. It's specifically being studied for AERD. If anyone afterwards is in hearing more about that, let me know and I can connect you. Those are probably the biggest new treatments that I would say are out there.
Okay, great. And if there's anybody that's taking notes like I am, do you happen to know the 6 biologics by name?
Oh, sure. Yeah. So we've got Dupilianab, which is Dupixent, Omalizumab, Omalizumab, which is Xolair, Xolair, and then Mepolizumab, Mepolizumab, and that is Nucala. Those 3 are approved for polyps and asthma. And then we have, let's see, Benralizumab, Benralizumab, which is called Fasenra. And that is not approved for polyps, just for asthma. We've got Sincair, which is Breslizumab, and it's Cinqair, only approved for asthma. And then the last one is Tezepelumab, Tezepelumab, M-A-B, and that's Tezspire, T-E-Z-S-P-I-R-E. That's currently just approved for asthma.
Great job with spelling too. Next up, we have Sally Benzon, who's asking, what about hearing loss related to AERD? Are there ways to manage it to prevent progression?
Yeah, you cut out, so I'm going to repeat the question. So hearing loss in AERD and ways to manage it. So I don't know if any of you participated. There was a questionnaire. I think it came from the database at Brigham and Women's, where Dr. Cahill and Dr. Laidlaw were working. And so there were about 600 patients with AERD that answered that survey. Main point of it was to talk about hearing loss and ear effects. And honestly, it's a much bigger deal than I had really appreciated. It's pretty common. So maybe 30 to 40% of you with AERD have issues with your hearing and ears. And probably it's related to the effusion or the inflammation that happens on the inside of your eardrum. That's, when you think about little kids and babies that need tubes, it's the same idea, where there's fluid up, and now when the sound comes, it can't get transmitted properly into the hearing nerve. And so a lot of patients actually with AERD have hearing loss, and a lot of patients have these symptoms in the inner ear, like feeling muffled and popping and trouble with altitude and clearing ears. So it's a huge issue for sure. In terms of managing it, honestly, we don't really know. The main ways that I manage it with my patients, and I think most of us probably would do it, are sort of the routine ways that we would already. So having ENT evaluate, maybe doing hearing tubes, getting hearing testing to see, ear tubes. And then the other big way to control it is controlling the underlying inflammation. And, most of the topical sprays and rinses and things that we have you do are just not going to get up anywhere close to the inner ear. So it's probably going to need to be some sort of more systemic therapy or surgical.
Okay. And related to that, from Nan Warshaw, can polyps also grow in the inner ear? How common is this for those with AERD?
So I have seen this. It's not common, but polyps can actually grow up into the inner ear. I honestly don't think that it's common to actually have detectable polyps on the inner ear, though. I think that's very rare. If that were starting to happen in a patient, I think that would make the case for sort of throwing the kitchen sink in terms of a very aggressive standpoint. I think more often it's really the inflammation, but not actual polyps that are in the ear.
Okay. From Barbara Bentz, is there any new research which explains the etiology of AERD? And she says she took a lot of aspirin as a child due to dental pain and is wondering how that may have contributed.
That's a great question, and I really wish I could give you a valid answer. It's sad, after 30 years of study in AERD, we really don't have much of an idea. I'll tell you the things we know. So we did a study at Scripps about 15 years ago and showed that patients with AERD are a lot more likely to have secondhand smoke exposure as a child. And there are actually some studies that show that may actually change some of the signaling in our allergy pathway, and some of those changes might be permanent. So that was one of the theories, is that childhood smoke exposure. We do think that there's a genetic risk, and so it might be that plus the combination of a genetic risk. And the other really fascinating idea is, in a very large study of AERD patients, about 500 patients, about 50% half the group felt like that they were totally fine until they had what seemed like a viral illness, like a cold, and they never felt right after that. And we don't know whether that was really a virus or whether there's something else that, seems like a viral infection that happens. But it really does make us wonder about whether this could be triggered by a virus. And a lot of what we understand about the inflammation in the sinuses and in asthma does make us concerned that it might be a virus. Honestly, probably not a specific virus like rhinovirus or coronavirus. It may just be getting a viral illness, and our body gets inflamed to fight off the viral illness, and then for some reason it never resolves the inflammation. I don't think there's any reason to think that having a lot of aspirin or NSAID exposure early in life really does anything. We think that that's sort of the last part of this whole process, and it only happens after the disease is pretty well established.
Interesting. Next question is from Beth Littlejohn, and she's asking, is AERD progressive? Will it continue to get worse?
I think what I would say is it's not progressive like the disease worsens over time, but what happens is as polyps grow and as sinus disease it does get worse. It just continues to get bigger and bigger. That tends to make asthma worse. And then you can reset it, right, by getting a steroid burst or surgery. But it's not like the disease accelerates over time. So for most people, it's sort of, once you sort of get the pattern, that stays about the same. Not to say that that pattern is good. It's not a good pattern if you need surgery every 3 years. But for most people, whatever their level of inflammation is, pretty steady for their whole life. It doesn't seem to get worse.
Okay. Next, another Beth Bender from Ontario, Canada. And she's recently unable to get budesonide. And she's asking if there's something else she can take instead.
Yeah, I've not heard if there's a shortage. I've not had any issues with getting that. We do use that a lot where we have patients put it in their rinses. You could talk to your local doctor. We do sometimes compound other topical steroids, like mometasone is one that can be compounded. So you might be able to just swap it out for a different steroid. That would be, I think, probably my best suggestion. There's probably even others besides mometasone, but that's the one I know for sure here in the States. We also can get compounded.
Okay, thank you. Next, Catherine Balint is asking, is aspirin desensitization still considered the gold standard for treatment of AERD, or has it been surpassed by other biologics?
Yeah, that's a great question. If you want to see a bunch of allergists have a polite argument together, come to one of our national meetings. We don't really know the answer to this. There's going to be a lot of factors. There's cost effectiveness that's important. So I would say right now there's not a gold standard. We have a lot of experience using aspirin therapy. But it's different for aspirin. There's different considerations because we sort of deploy it right after surgery. It's different with some of the biologics. You don't necessarily have to do it right after surgery. So I would say right now we just have a lot of options, which is great because for many years we didn't have a lot of options in AERD.
Okay, thank you. And we'd like to hear more information on the arguments going on. Next, Charmaine Mason asks, is there a link between AERD and IBD?
So I'm not aware of any link between AERD and IBD. So IBD are Crohn's disease and ulcerative colitis. Those are autoimmune conditions in the gut. There is a link between AERD and something called EGID, which is eosinophilic gastrointestinal diseases. Those two things do seem to happen more often together than we think is just chance. But they're very different on biopsy and on endoscopy. It would be unusual for those to be confused. But if you are having a lot of GI symptoms and you have AERD, then I would at least consider talking to your GI about that and maybe getting a biopsy.
Thank you for that. Maybe difficult to answer, but we'll give it a shot. Sylvia Foster asks, which biologic has less side effects, but helps with nasal polyps as well as asthma?
Yeah. The truth is the three biologics that work for both polyps and asthma. So you're already down to three. So Xolair or omalizumab, Nucala or mepolizumab, and then Dupilianab or Dupixent. So those are the three choices that we know have been studied and work for both. And honestly, they all are very, very safe. They all have very limited side effects. There's slight differences between them, but truthfully, there's no major reason from a side effect standpoint to pick one over the other. And it's great. I mean, none of them are immunosuppressive. So, if there's one that you and your doctor really think either fits best with your medical history or your insurance plan, you just go for it. And then if that doesn't work, you've got two other options.
All right, great. And then somebody actually dropped the spelling and names of the biologics in the chat if anybody wants to go take a look at that. Next, Vivian Metz is asking, is our asthma atypical? Is it developed as a part of ERD? And should it be managed differently?
Yeah, that's a great question. So I would say yes and no. We view asthma as a syndrome, and there's probably 5 or 6 different distinct categories of asthma for how we think about it, and AERD is just one of them. So you're correct. We call it actually an endotype. It's a very precise form of asthma. And yes, it should be managed differently. It should be managed in the context that we know you have AERD. And so thinking about controlling the sinus disease, that's very critical. Your asthma will never be well controlled if we're not controlling the sinuses. So yes, part of it should be managed and treated differently, but then a lot of it is going to overlap and be very similar. The inhalers are all going to be the same. A lot of the pill medications are going to be the same no matter what kind of asthma you have. So I would say yes and no to that.
Interesting. Next, we have Lynn Ann Bartlett. And she wants to know, is there research on vitamin D in higher doses as an alternative to prednisone for chronic inflammation and polyps?
I don't think there's any solid evidence on that. It's definitely not saying it as an alternative to prednisone. Prednisone is extremely potent. And I don't think you're going to be able to get a similar effect with vitamin D3. The way that we sort of think about this, at least my best way of thinking about vitamin D3 is it's sort of like a very strong supporting role in our immune system. And so if it's low, you may have more trouble with inflammation. And so that's why it's important to have it be normal. But it doesn't seem like pushing it up to high doses necessarily has a big beneficial effect, at least from what I've seen in my practice and in the studies. So we do want to monitor it. We want to really make sure that it's not low, but just going at a high dose and seeing if that can have a prednisone type effect, I doubt will be successful. And I don't think there's any study on that.
Okay. So it looks like we have about 10 minutes left, and we might be able to get to a couple questions in the chat. So if anybody else has additional questions, please drop those in the chat. We have 2 from Susan Krumpak, who is asking about biologics. She's concerned that the medication can cause large vessel and connective tissue disease. Is there any truth to this? As well as her ENT mentioned that at some point she may want to go off Dupixent to see if it improves. Do you find that to be true?
Yeah. So the first question is about the large vessel and connective tissue disease. As the question is stated, that's not true. They don't cause those problems. I think maybe where that's rooted is that for all of the biologics, they're studied in patients that have severe asthma, and a very, very small percentage of people with severe asthma have an underlying vasculitis. So in all of these studies, we know that one of the outcomes is that 1 or 2% of the patients are going to get diagnosed with a vasculitis, and that's a very severe problem. And it happens in all of the asthma studies. So it doesn't seem to be a caused, we don't view this as a cause by the biologic. We view it as sort of, if you take any big group of asthmatics and then you follow them for a year, like all of these studies do, you're going to see it a few times. So it's in the packaging. We talked to the patient, we talked to you about, that these things are sometimes observed, but we do not think that one causes the other. So I think that's where that question comes from. Talk to your own doctor about that. We do monitor for that in anybody because we worry that this could occur in any of our patients. Yeah, so that's where that one is. The second question was whether stopping a biologic like Dupixent to see if things get better. And the sad fact right now is we don't really see patients with AERD have it just go away. There are rare cases where we think that might have occurred, but the general observation is that this does not go away. Now, what we don't know, and we won't know for a little while, is what if you're on one of these for 5 or 6 years, or maybe 10 years, and you've been, completely controlled for a long period of time? Is that enough time? And that'll have to be a study that we do. But currently, for patients that have just been on it for a year or two, I've not had any success with a patient stopping it and being able to remain off of it.
Interesting. Yeah, it'd be interesting to know the long-term effects of this. Next, Nadine Norp asks, do you think T3 thyroid supplementation would mimic steroidal effects similar to great results of medication such as prednisone without the side effects?
No, I don't think so. I would say that's similar to the vitamin D question as well. You need to have your thyroid well regulated to be healthy. But if you took a lot of extra T3, you would also run the risk of having side effects from over supplementation, and that can be bad on the bones, and there's some downsides to it. But that really shouldn't have any significant steroid effect. So I don't think that would give you results.
Okay. All right. So, question in the chat. This is from Jennifer D. Is it important to know one's eosinophil level? Does it drive different treatment paths?
Yeah, that's a really good question. So yes, I do think it's important. It's pretty standard now for allergists to get a routine blood count. It's just a CBC, the standard test that we all get when we go to the doctor. And you can actually look on there, as long as it has, it's called a differential, you can see what your eosinophil count is. And most of the biologics that we've talked about work better when the eosinophil count is higher, usually above 0.3 or 300. The funny thing about AERD is it is very eosinophilic. So almost every one of you is going to have a mildly elevated eosinophil count. So when we see an AERD patient, we still want to know that, but we sort of assume it's elevated. It's a little different than just sort of a general run-of-the-mill asthmatic that might not have it be elevated. But we still want to do that as part of it. And then the other reason is that sometimes we can be confused between AERD and other severe asthma syndromes, or like the vasculitis I mentioned. And in that case, the eosinophil count is very high, like in the thousands. So that's another reason to get it up front, just to make sure we're correct in our initial assumptions on the diagnosis.
Thank you. Um, Rick is asking, is there any association with nosebleeds, either from the aspirin or the nasal rinses?
Yeah, I'm sure. So, aspirin itself won't cause a nosebleed, but if you have a vessel that starts to ooze and you're on aspirin, you're going to bleed more. So there's definitely going to be an association, right? When you have a bloody nose, it'll be harder to stop it. The rinses themselves, I think, are less likely to cause bloody nose. We more commonly see bloody noses with the steroid nose sprays. Some of that's just literally related to the fact that the spray hits our septum. And when it hits the septum, there's a bunch of blood vessels right there, and over time it can irritate it. So a lot of you probably been told by your allergist, put the spray in and then aim away from the middle. So that can sometimes limit it. But the steroid itself can be a little irritating to the mucus lining in the nose, and we sometimes see people have bloody noses from that as well. So yeah, there's definitely a link. It's more related just to the therapy, not to the disease itself.
Got it. Jenny Worthing is asking if there's any relationship between polyps or any other tumor growths.
There's not, which is good news. It has zero to do with polyps in your colon or polyps other places that might be pre-malignant. There's no chance that the inflammation polyps in AERD turn into cancer. So it's really very, very different the way we think about it. These are just like little pockets of inflammation, whereas polyps in your colon are really precancerous, and if left alone and not monitored, would in the colon would turn into cancer.
Okay. Let me see if there's any more. Here's one from Jennifer Beeson. How much benefit do you see with budesonide rinses?
So I think you can get a really good benefit. The problem is it's not really well studied. As all of you probably know that do this, this is not an FDA-approved treatment, and so we're using budesonide off-label. And because of that, we can't. It's hard to do big studies to really see exactly how beneficial. But there are definitely studies. There was just a study out in the last month or two looking at budesonide rinses in AERD and showed that they can be helpful. I think the better way to think about it is, the polyp tissue is just hard to get at with a nasal spray, with a typical nasal spray that are over the counter. So that's why the rinses are, far better, because you're getting the deposition way higher up where the polyp is.
Okay, great. And last question. This is from Laura from the Samter Society, who does all our great graphics. Talking about hearing issues, would it be a good idea to get our ears checked every few years?
Yeah, to be honest, I think that is actually a really good idea. Um, if 30 to 40% of patients ultimately start to develop hearing issues, I think it's one of those things that can creep up on us, right? And you don't necessarily know it's happening. So I actually think that's a really good idea. It's not, to be honest, I'm really glad you asked that question, because it's not something I'm routinely recommending to my patients, and I think I will now. I think we should all have a baseline, and then you can sort of follow it over time. And if there's any concern about some early hearing loss, maybe we're a little more aggressive in some of our therapies.
All right, and with that, looks like we're out of time. So, on behalf of the AERD community and the Center Society, Dr. White, I'd like to thank you for your time and your continued support. Also, I'd like to thank the Scripps Clinic and Carlin, who worked with us to make this webinar happen, as well as the whole team at the Samter Society. Also, please show some love to Dr. White and team in the chat. And last thing, I encourage you all to go and try and donate to these amazing research centers that Dr. White, Dr. Laidlaw, and Dr. Basso work throughout the year to help patients like us. So thank you again, Dr. White.
Thanks. I saw a couple things in the chat about clinical trials, so I'll just forward this on to the Samter Society, and then you guys can all have the info on some of those options if you're interested. Thanks, everybody.